Hi, I'm Cindy Crook, and I'm the Director of Marketing at Duncan Regional Hospital, and welcome to DRH Live. And today our guest is Dr. Najera, who is board certified in internal medicine, hematology, and medical oncology with the Cancer Centers of Southwest Oklahoma. He's on our Duncan campus, which is the Taylor Norman McCaslin Cancer Center. And March is National Colon Cancer Awareness Month, so Dr. Najera is going to talk about your colon and anything about it that people have questions with.
Yeah, well,
welcome.
Thank you. So hi everybody, so we're going to talk about colon cancer today. So colon cancer is a relatively frequent type of cancer, and we recommend screening because everybody is at risk for colon cancer. In general, we recommend a colonoscopy starting at age 50, but sometimes we can also see colon cancer in younger people below the age of 50. So by any chance you have a family member who's had a colon cancer before age 50, usually the rule is to have a colonoscopy 10 years before the age of that diagnosis. So if you have an uncle or a brother who was diagnosed with colon cancer age, for example, 45, then you should get a colonoscopy at age 35. Now, colonoscopy is, as we call, the gold standard, so that's considered the best test to diagnose colon cancer, but there's other screening tools that are available. For example, there's a stool card, which you can do once a year. This checks blood in the stool, and so if there's blood, then sometimes you'll need additional testing, which would be a colonoscopy. It's not a perfect test because sometimes you can have blood for other reasons like hemorrhoids, but in general it works very well, and this is also considered a good screening tool. So that's the stool cards for checking blood. There's a different stool card called Cologuard, and this checks for possible cancer DNA in the stool. So this can detect polyps or colon cancer. It's called Cologuard. You also need to put stool on the card, and this is done every 3 years. Also, if you ever have a positive result, then you'll need a colonoscopy. And then the last screening tool is something called virtual colonoscopy, which is basically a CT scan, and it tries to image polyps inside the colon. Also, if something is seen, then you'll need a colonoscopy. So in general, I usually recommend the colonoscopy, but again, at least having the stool cards, if you want to avoid a colonoscopy, is a good starting point. But if it's positive, then you'll need a colonoscopy. Once you have a colonoscopy, if it's completely clear, it doesn't show any polyps, then you don't need another one until 10 years later. So sometimes it's worth it because you'll go 10 years without having to do anything else. Basically what they're looking for when they do a colonoscopy is these polyps, because that's what over time could turn into a colon cancer. In general, we say about 10 years, so that's why if it's completely clear, we wait as far as 10 years to do another one. But if there's polyps, then those need to be removed depending on the number and size. Sometimes you might need another colonoscopy a year later or 3 years later. But again, that's good because you're preventing a colon cancer from developing by removing those polyps. So then, let's say a colon cancer is actually found. So when this happens, then the next step is to do scans to try and determine if by any chance the cancer has moved from the colon to any other areas of the body, which a lot of times the case is that it hasn't moved, so that's when it's fortunate, because that's then considered either a stage 1, 2, or 3. When the cancer moves to other parts of your body, then that's considered stage 4 cancer, and most of the times, unfortunately, it's not curable. So that's why we do all this emphasis and screening and prevention and detecting colon cancer early. So let's say the scans are done, there's no cancer anywhere else in the body. So then the next step is to see a surgeon and have the actual cancer removed. So once the cancer is removed, then the patients should be seeing the oncologist like myself. We go over everything that was found at the time of surgery, and if the cancer moved to the lymph nodes or we see any high-risk features that are concerning, then we might recommend chemotherapy after the surgery. Chemotherapy usually is about 6 months. Sometimes it can be shorter if it's a lower stage colon cancer and low risk. But in general, it lasts about 6 months. after chemotherapy is finished, then patients need to be monitored because unfortunately sometimes the cancer can return. So again, this is why we do a lot of emphasis in screening. Another part is prevention. So colon cancer, some research has shown that it's related to what we call a Western diet, so a diet that is very high in fat, like eating a lot of bacon, nitrates, which is something that's in processed meats, like hot dogs, for example. So all those tend to increase your risk for colon cancer. So it's healthier or better for you if you try to eat as much vegetables and fiber as possible, and also try and exercise, because exercise has been shown that in general can keep cancer away, not just colon cancer, but other types of cancer as well. So I really encourage everybody to try and exercise as much as possible, and also try and keep a weight within normal limits, which is difficult with all the, as busy as we are and how easy it is to get fast foods and things of that sort. But again, it's something that's good for you in the long run.
So is that the test right there?
So for everybody here, we have an example. So this is a type of stool test. This is something that will check for blood. This is offered here at our cancer center. It's free of charge, and it has, again, good accuracy, about 70% accuracy. So here's an example just to see how small it is. And this is something you pick up, you take home. You follow the instructions, then you bring back to the cancer center, and then even the same day you bring it back, we'll have the result back to see if there's any blood. If there is blood found, then you need to get it with your family doctor to get a referral for getting a colonoscopy. This is offered here, completely free of charge. You just pick it up and then bring it back. We also have the option of looking into Cologuard for you, but that is something that would need to be covered by your insurance. But most insurances cover it because it's FDA approved to screen for colon cancer. But that is something that the company who does the Cologuard will need to be contacted. They'll get with the insurance and then send you the kit, and then the kit can be processed. So that's another test that can be arranged for. But the one we have here readily available is the Hemocold type test.
Great. Well, one question that we have is from Alice, and she had asked that her dad had colon cancer, and he's fine now. But she said, should she be concerned about herself?
So, depending what age her dad is when he was diagnosed. So, if it's a colon cancer that happened at age 50 or higher, there's a higher chance that it's probably what we call sporadic colon cancer. But when it happens below the age of 50, that's when we get more concerned if it could be something hereditary. And in those cases, we need to look for a syndrome, especially a syndrome called Lynch, which is something that will increase your risk for colon cancer at an early age. Now, having said that, nowadays, everybody who gets diagnosed with colon cancer, now we do certain testing of the tumor itself to look into the possibility if there might be this Lynch syndrome. So now everybody, all their colon tumors get tested for certain genes that if they're altered, that increases the risk of a Lynch syndrome, and then that person who was diagnosed will get blood tests. So it could increase your risk, higher chance if her dad was younger than 50.
So has the treatment for colon cancer throughout the years that you've been in practice, is it better? Is the rate of survival better nowadays versus, say, 20 years ago because of the treatment or because of the colonoscopy testing?
I think what probably has done the biggest impact is screening, because unfortunately once the cancer moves out of the colon and becomes stage 4 cancer, it's not curable. Chemotherapy has improved, so patients with stage 4 colon cancer are living longer, but ultimately they'll die of the cancer. So right now most of the stress is in preventing colon cancer or finding it early. So probably the biggest impact in mortality is screening and getting those colonoscopies or stool studies, etc., to detect it early.
Well, speaking of the testing, the screening, the colonoscopy, that's a lot of the question because that doesn't sound like a fun test. So one of them, Joe had asked, does it hurt? Does it take long? And they heard the prep is not fun.
Yes. So the biggest complaint probably is with the prep. So people have to drink this substance to help them pretty much empty their colon. So basically what it causes is diarrhea and cramping. So people will have cramping, they might get nauseous, they'll have the diarrhea. Now the substances has changed, so now there's even newer substances that might be milder as far as causing abdominal cramping and nausea. Also the diet, sometimes the surgeon or the gastroenterologist will advise patients to eat certain type of diet, but now that, or even be fasting, but now they also found that maybe eating something like a soft diet, clear diet might also be enough, so that has also improved. So there has been some improvements to make it easier on people. Ultimately there'll still be some cumbersome things with the prep, but again, I strongly recommend that because if you have it done, it's clear, then you go 10 years without having to worry about anything if they don't find any polyps. And all of these other tests, if they're positive, ultimately you still need that colonoscopy. So a lot of times just going ahead with that colonoscopy, it is burdensome, it might be worth it.
Okay. And so Bob wants to know, what is a polyp?
So a polyp is like a rounded structure, like a little ball, if you want to think about it that way. So most of the times polyps are protruding. They look like a ball, so there's something that they'll see over the mucosa. It's like a little ball, and then they'll remove that. Now sometimes there are flat polyps, which they're more rare, but sometimes those can be seen also through the colonoscopy because they see an area that looks abnormal, and then they can also biopsy that and remove that. But most of the times the polyps are growing upwards and look like a ball.
Do all polyps become cancerous?
Most of the times, unfortunately, yeah. So that's why ultimately all polyps should be removed. Now some of them are more aggressive than others, so some polyps could even turn into colon cancer faster, but most of them will take about 10 years. So there might be a possibility that maybe some of them will not turn, but when doing the colonoscopy, the surgeon or gastroenterologist does not take chances, so they remove the polyps they see.
And you're not the doctor that would do the colonoscopy, correct?
No.
It's a surgeon that would do it.
It'd be either a general surgeon or a gastroenterologist who are highly trained in doing colonoscopies and identifying polyps and removing them.
Okay. And you touched on it, but anything else that you can say that will help prevent colon cancer? You mentioned diet. Anything else that you can think of?
So, I mean, again, mostly diet and exercise. Now, there has been some research looking into aspirin. And aspirin, at a standard dose, which is 325 milligrams, has been shown to decrease the risk of colon cancer. Now, as of today, we're not recommending aspirin yet for everybody just for that purpose of preventing colon cancer because, unfortunately, aspirin also has some side effects. It can cause gastritis in some people, ulcers, etc. But if somebody's already taking an aspirin because of their hearts to prevent a heart attack, then that's an added benefit that it can help prevent the colon cancer.
Okay. And there's no, if you're unfortunately diagnosed with colon cancer, is it person by person how the treatment is decided, whether it's radiation or chemotherapy or both?
So, exactly. So all depends on the stage and also the type of cancer. So a cousin of colon, which pretty much gets grouped with it, called rectal cancer. That type of cancer, which is also found through a colonoscopy, the treatment is a little bit different. So if somebody has a rectal cancer and it's very early, they can go straight to surgery, and sometimes nothing else needs to be done after the surgery. But sometimes if the rectal cancer is more advanced, it has moved to the lymph nodes, then people will require radiation and chemotherapy and afterwards have surgery. For colon cancer, the first step is surgery and then in some cases chemotherapy. So the treatment might vary depending on if it's colon or if it's rectal and what stage it is. And so that's something where it's a multidisciplinary approach. It's done with the surgeon. If it's a rectal, we involve the radiation doctor, and then the medical oncologist like myself, who ultimately designs the plan and monitors patients moving forward.
Just a kind of a clarification, because I know here at the Cancer Center, there's yourself, and then there's Dr. Curley, who is radiology. Maybe you can explain what's the difference between being the medical oncologist versus what Dr. Curley is.
Very, very good. So I myself am a medical oncologist, so I administer chemotherapy for patients, which is something that's mostly done IV. We also have oral forms of chemotherapy, and then I do most of the monitoring and surveillance for patients, so patients might see me for a long time. Dr. Curley, who is also with us here at the Cancer Center, he's a radiation oncologist. So what he administers is radiation therapy, which is indicated for rectal cancer. It's not indicated for colon cancer per se, and it's also used for other types of cancers. So Dr. Curley will see a patient, decide if radiation is appropriate, and then deliver the radiation and follow up for the patient to check for complications of radiation afterwards.
Great. Well, we have a question from Haley, and she asks, are polyps a good indication of future problems in regards to colon cancer?
Yeah, so most cancers will come from a polyp. So if in somebody you see the polyps, then you follow that patient closer, and you might do a colonoscopy in a year or 3 years or 5 years, depending on the number and size of polyps. There are some cases where somebody might have a syndrome called Lynch, and this will increase your risk for colon cancer, sometimes even cause colon cancer without polyps. So that's something that is followed very closely, and sometimes might even need the colon to be removed. But that's more rare. Most typical colon cancers will arise from polyps.
Are there any studies, what are those called?
Clinical trials?
Yes, thank you. Clinical trials on colon cancer.
Yeah, so there are numerous clinical trials, including prevention that has been mentioned here, like incorporating diets high in fiber, clinical trials on ways of preventing it, like we discussed before, aspirin or other types of anti-inflammatory type medicines, and then clinical trials for chemotherapy. So there are numerous clinical trials throughout the country about colon cancer.
Okay. I'm going to kind of go off on just talk about the Cancer Center. Here at this Cancer Center, do you guys treat all types of cancer?
Yes.
You do?
So most frequently, the most common type of cancers are breast, lung, colon, and prostate. So we mostly see those types of cancer just because how frequent they are, but we also see other types of cancers that are more rare, like pancreatic or lymphoma or multiple myeloma, which are types of blood cancer. So we treat all types of cancers.
But do you treat children here?
We don't do pediatric type cancers. So usually those will need to be seen by a pediatric oncologist.
Okay. Another question, Chris asks, do you discuss patient care with other doctors?
Yeah, so we do have our multidisciplinary meeting, which is done twice a month. In these meetings, besides myself, we have the radiation oncologist, which is Dr. Curley, radiologist, for example, Dr. Elfring, who's an excellent radiologist here at our hospital, the surgeons, Dr. Che Miller, who's an excellent surgeon, Dr. Woods, who's also a surgeon, Dr. Whedon, who's also an excellent surgeon. And between all of us, we discuss cases. There's also pathology, who discusses biopsies. And between all of us, everybody gives their opinion, and we come up with a plan for our patients. So it is done in what we call multidisciplinary approach, with different specialties being involved in the decision process.
Okay. Don't see any more questions out there. I'm going to just say it out there. If anyone has a question, to go ahead and submit it now. So tell us a little bit about your background.
So currently I'm a hematologist oncologist, so I see both blood disorders and cancer. And cancer, both what we call solid type tumors, which is cancers that could arise from the breast or colon or lung, and then blood type of cancers like certain types of chronic leukemias or a type of blood cancer called myeloma. Before becoming an oncologist and hematologist, I studied internal medicine for 3 years. I did that back in Texas, in San Antonio, and then I did my specialty in oncology and hematology in Florida. And now I'll be here in Duncan for almost 5 years now.
Oh. Well, that's great. I think that's all we have. No one has submitted any questions. I'm sorry. I'd like to thank Dr. Najera for sharing his expertise on this subject. If you have any questions, you can see the phone number right here. Any of the staff at the Cancer Center would be glad to answer your questions. And thank you, everyone.